Okay, so this is part B to chapter 20. Last time it cut me off, so we're going to go at it again. Remember, we were talking at the preterm newborn. And so the preterm newborn, what does that look like exactly? It's often a tiny infant. It's going to be red, scrawny looking. Their skin kind of looks immature, transparent. You can see through it, see the vessels. They're going to have a hard time often with thermoregulation. Remember, more skin surface than they have fat and muscle tissues. Respiratory distress, often they don't have that surfactant in their lungs to really help them with the breathing. Oftentimes they might not have had the vaginal push, and so they're still trying to get rid of that fluid. They need high caloric, they have a high caloric need. However, they're not often able to digest the food because of an immature gut. Alright, so treatment of complications. So these are 4 of the complications that can happen with the preterm newborn. You'll see respiratory distress syndrome, and that is going to be the hyaline membrane disease. And what that's talking about is when you're thinking about the lungs and the alveoli, those sacs that should have air in them now, they just completely collapse. They go completely flat because they don't have the surfactant. Preterm newborns are lacking surfactant, and so often we'll have to give it to them to help expand those alveoli and to keep them inflated, where they just don't completely collapse and stick to one another. So the treatment for that is often giving them surfactant and just allowing them to grow. They'll do CPAP on them as well, get that positive pressure in their lungs to help open up those alveoli. The intraventricular hemorrhage, that is going to be the bleeding into the brain's ventriculars. 2 factors that place the extremely premature infant at risk for IVH is, first, the developing brain has very fragile capillary network, and so it can easily rupture with the cerebral changes. And then the second is that the preterm newborn may be unable to auto-regulate cerebral pressure, just too immature, and that leaves the newborn with little protection from all the pressure fluctuations. Retinopathy of the prematurity, this can cause blindness. It's a degenerative disease of the retina, and the best treatment for this is just going to be prevention. Necrotizing enterocolitis, NEC, is going to be a necrotic disease of the gut, the intestine. Babies often are feeding poorly. They'll experience lethargic, temperature instability, vomiting of bile, and abdomen distension. Often they'll also find blood in their stools. An X-ray will confirm the diagnosis. And so with this, we'll do oral feedings. We'll discontinue oral feedings. Any kind of nasogastric section will be applied, and we'll try and just let that gut rest for a little bit. They'll give them antibiotics and hopefully be able to start them back on their nutrition. Of course, when babies are small, they need nutrition. However, sometimes their gut just isn't mature enough to handle it. We'll also introduce microbes to them as well to try and get a healthy gut. Okay, so the nursing process for the preterm newborn, it's going to include maintenance of oxygenation, continuous electrocardiorespiratory monitoring, frequent manual monitoring of vital signs, thermoregulation, infection control, hydration, provisions of adequate nutrition and development care for the newborn, and some emotional support for the parents as well. Oftentimes they will be in the NICU, and they'll be in incubators, that thermoregulation, trying to warm them up. And so the parents don't always get to hold their babies up close. So it's promoting bonding, promoting touch. And when we can, we'll allow the babies to come out, and that the moms and dads can hold their babies as well. The nursing diagnoses can be ineffective breathing pattern related to immature respiratory system, thermoregulation. We're always worried about that baby's temperature. We want to keep them swaddled up. We want a hat on them. We want to do anything we can to keep them warm. We're going to be taking rectal temperatures on them to make sure that they are above 97.7 and just staying warm. They're going to be at risk for fluid volume deficiency, imbalanced nutrition, activity intolerance. Remember, we're going to do cluster care with them. Try and make where respiratory therapists, everyone does all of their care all at once, or all of our nursing care. We're going to cluster it together and do it all at the same time to help decrease the stress to the infants, that they're not getting too worked up, we're not depleting their energy. Also, with the very premature newborns, their neurological system is not developed, so we are going to be trying to keep it low stimuli. We're going to swaddle them up, we're going to put hats on them, but we're just going to try and keep a low stimuli environment, so whatever that means. Not going loudly tapping on the glass, trying to make them look at you, or teaching the parents not to do that. Dim lighting, just keeping it a calm environment for them. That's part of the protecting the neurological status, maintaining fluid and electrolyte balance. Of course, they will have IVs, they will be breastfeeding, bottle feeding, whatever it is. At this point, often the mothers can't really breastfeed in the NICU, depending on how critical the baby is. If the baby's doing well and is just small, they might promote breastfeeding. However, if they have any kind of respiratory issues, we'll encourage the mother to pump her milk, and then we'll feed the baby with a bottle. And that's something that the parents can do to help promote bonding as well. Maintaining adequate nutrition, we talked about that. If they're not able to bottle feed for whatever reason, we might do gavage feeding, pass an NG tube down into their stomach. Implementation, preserving skin integrity. That skin is very frail, it's red. We have to make sure that we're turning them, putting padding underneath their knees, and just lotion on them if they need lotion, just making sure that there isn't any skin breakdown. With the NICU, you're also thinking about the tubes and being taped, so we have to check that tape, remove the electrodes, and make sure that there is no skin breakdown there. We'll be supporting growth and development for them. A lot of the babies in the NICU are just growers and feeders, and that just means that they don't have any problems other than the fact that they're just not taking in PO well. They're not taking in input, they're not growing. And so some of those babies are just there as growers and feeders, and they're not real critical. It's just getting that nutrition into them. Of course, our jobs as nurses is always to reduce that parental anxiety, to educate them and let them know what's going on with their baby, improving parenting skills and family functioning. Some of these babies might be in because the mother smoked or did drugs during pregnancy, and so we need to let them know that smoking will put the babies at risk for other health-related complications, and to encourage the mothers, the parents, the dads, whoever it is, grandparents, to stop smoking, showing them how to cuddle, how to swaddle, how to just bond with that baby. And then evaluation, goals and expected outcomes. You want to see this baby doing well. You want to see the baby move out of the NICU and to go on and live a happy, normal life. Now we're talking about the post-term newborn. So this is the baby that has been in the womb for too long, perhaps 42 weeks plus. Predisposing factors can be first pregnancies between the ages of 15 and 19 years old. Those mothers sometimes carry their children a little bit longer. Women older than 35 years with multiple pregnancies, and then certain fetal anomalies can also affect that. What you're going to see, characteristics of that post-term newborn, is going to be real leathery skin. It just looks like they've basically been baked too long. There's not going to be much lonego. There's not really any vernix. The scalp hair is going to be abundant oftentimes. Fingernails will be very long. There's going to be little subcutaneous fat, and they often appear very long and lean. One characteristics of this baby is that they're just ravenous eaters. They are ready to eat and they are hungry. Potential complications, you could have polycythemia, which is excess red blood cells, or a big one is going to be that meconium aspiration syndrome. With the meconium aspiration, they've been in too long, they're already past the meconium, or the stress of labor can often cause them to pass that meconium stool, and then initially they'll breathe it in, and so this can put them at very high risk. The polycythemia is excess red blood cells, and that can actually put them at risk for cerebral ischemia, so that's a very big complication there as well. Treatment is going to be early ultrasounds, trying to figure out how old this baby is. Oftentimes, though, the mother will not have any kind of prenatal care. She'll come in and will have a post-term baby. Okay, sorry, Miss Sharp just scared me to death. But anyways, moving on. They're going to be ravenous eaters at birth. We're going to monitor their serial blood glucose. Because they're such large babies, they will have a tendency to drop that glucose. They'll be often producing too much insulin. And so we're going to watch them really carefully and make sure their glucose does not drop below 50. Provide a thermoneutral environment. Make sure that they are warm babies. Respiratory disorders, acquired disorders. Okay, so with respiratory disorders, acquired disorders, we're going to talk first about transient tachypnea of the newborn. And what this is just that that baby is breathing way too fast. Contributing factors, clinical manifestations. Often you'll see that their breaths per minute is going to be greater than 60. They're going to have difficulty feeding. We do not feed any newborns that are breathing over 60 breaths per minute, because it has, you think about that, here it is, that tissue that covers up the epiglottis, covers up the airways. Whenever you're breathing so fast, that's going in, you're trying to swallow, it has a tendency to go straight into the lungs, and it puts them at risk for aspiration. So any infants that have is breathing 60 breaths per minute over, we will not feed them. We'll hold their feedings. Often you'll do an x-ray and you'll see fluid in the central portion of the chest. You can do arterial bloods to see this. Treatment's going to be IV fluids, gavage feeding, not just feeding by the bottle, but going past into the stomach with an NG tube or whatever tubing they use to feed him with, so that it goes past the airway into the stomach, and then O2 until this problem resolves. Of course, meconium aspiration is going to be, and it will put them at risk for developing this. With meconium aspirations, clinical manifestations, that baby, whether it was from stress or just being in there too long, pooped in utero, they got into the amniotic fluid, and then when they took that first breath, they breathed it in. We can do suctioning on this. We can, for these babies, of course, we're going to be suctioning their mouth and their nose whenever they initially come up, but we can also do deep suctioning as well to relieve them of any of that meconium. Sometimes they might have to be intubated. We hope that they don't, but they might need intubation and oxygen and antibiotics as well. Acquired disorders goes along with sudden infant death syndrome. Okay, so contributing factors, we're not really sure what exactly causes it. It is a leading cause of death for babies that are 7 days old all the way up to 365 days old. 2 to 4 months are at highest risk. We're going to teach the patients to lay the babies on their backs, supine, not on their sides, not on their stomachs. Grandma comes over, well, we always did this. Yes, but since it's very huge risk, we know a little bit more about it, and it's always going to be on their back. There's not really a single causative, and there's not a single cause identified, but we do know that circulation in the room, whether it's a fan or having the air set at like 68, that seems to be a good temperature for babies. Having a fan circulating, using a passy, being on their back, and no big fluffy blankets or anything like that. There are home apnea monitors. You'll find that babies who died of SIDS, often their brothers or sisters, it has a genetic tendency. So if a parent had a baby who died of SIDS earlier, teach them to get an apnea monitoring system at their home and to use it. We don't want that second child to suffer from this as well, and that's one way we can help them in that. Hemolytic disease of the newborn. You guys should know this backwards and forwards now. RH incompatibility. The mom is RH negative, the baby is RH positive. That mom forms antibodies towards the baby. It causes them to break down their red blood cells. The destruction of the red blood cells will lead to severe fetal anemia. The anemia can cause that baby to have pathological jaundice. Remember, pathological jaundice is jaundice within the first 24 hours. And then if this condition is not fixed, it can lead to kernicterosis, Kernicteres, which is excess bilirubin neurons in the brains and spinal cords, and that can lead to injury or even death. So it's a very serious disease. Treatment for RH incompatibility is going to be giving the mom Rogam, the shot Rogam. Remember, the first baby is usually not at risk for this. It's always the second baby. However, if the mom has any test done, like an amniocentesis, where that mixing of the fetal blood and the maternal blood occurs, then we will automatically give her Rogam. Aversion, when that physician goes in and is trying to turn that baby, that can cause fetal blood to mix with maternal blood. We would give the mom Rogam in that situation as well. Large for gestational age. Okay, with this one, a newborn of a diabetic mother. So these babies are going to be the big plump babies. They're going to be very large for gestational age, meaning that they are in the 90th percentile of height or weight or head circumference. Plump, full face, bulky shoulders, and they're coated with vernix. The placenta and the umbilical cord are often very plump, very oversized as well. With these babies, it's going to require specialized, careful observation to make sure that their blood sugar does not drop below 50. If the baby's blood sugar is dropping below 50, we're going to do a heel stick on them. We're going to see that, and we're going to encourage the mother to feed. If it does not come up after feeding, then we might have to go to dextrose, but we're going to try feeding that baby first. Watching for signs and symptoms, that shrill, high-pitched cry, lethargic, they're not tight, they're not flexed. We're looking for all of those. Remember, with the bulky shoulders on these babies, we're going to be checking their clavicle and make sure that they don't have shoulder dystocia, that they did not fracture their clavicle in that. Newborn of a mother with substance abuse. So fetal alcohol syndrome, remember the clinical manifestations, looks a lot like this baby. Small eye openings. They'll have a real thin upper lip, large bridge across their foreheads, and oftentimes with these babies, they will be very irritable. They'll have disturbed sleep patterns. And this is for not only fetal alcohol syndrome, but also the substance withdrawal. You'll see a very similar thing. Shrill, high-pitched squealing, frequent sneezing, constant movement, tremors, tachypnea, diarrhea, hyperreflexia, clonus. The best thing for these babies is to swaddle them up. They are going to cry. They have to get that substance out of their system. And so we have those grandparents who will come up and they're fabulous and they'll hold the babies and cuddle them, but we're watching to make sure that they're not overly stimulated. They need the dark environment. They need low stimuli, not a lot of noises, and so that's what we're going to do for these babies. And then a newborn with a congenitally acquired infection. All newborns are going to be at risk for infections. A variety of organisms can cause the newborn infection. Treatment consists of intensive antibiotic therapy, IV fluids, respiratory therapy, and then of course other supportive measures. So if you have any questions, look it up in your book, come ask me, but you guys should do great.